Hello, this is Team Amaranth, and our project is predicting liberation for mechanical ventilation in the intensive care unit. Mechanical ventilation is a short-term intervention for acute respiratory failure and is required by 20 to 40% of U.S. ICU admissions. The appropriate timing of patient liberation from this ventilatory support is critical to avoid complications and reduce healthcare costs. We aim to create models that could accurately predict independence for mechanical ventilation, as they would be pivotal in supporting clinicians' informed decision-making, improving patient outcomes upon extubation, and decreasing ICU expenditures.
Our dataset consisted of 9,781 adult patients recorded in Johns Hopkins Precision Medicine Analytics Platform, also known as PMAP. These patients were filtered to include only those who had records of mechanical ventilation during their ICU stay. As shown in Table 1, most of these patients were geriatric white males with a recorded history of circulatory issues and/or cystic fibrosis.
So method here is the overall pipeline of our study. We first do the inclusion and exclusion on the raw dataset that is pulled from PMAP, getting around 14,000 patients, and then we conduct the data imputation based on the clinician imputation and the data cleaning to remove the erroneous samples points and the extreme outliers. We end up with around 9,000 patients, and we split it up into train validation and test set with ratio of 8 to 1 to 1. We apply 6-hour observation window to each patient to get around 21,000 windows for the final data set. We use SMOTE to address the class imbalance problem. Based on the data set we got, we found out XGBoost performed the best, compared with 3 machine learning models and 4 deep learning models with respect of the F1, AU-ROC, AU-PR, and negative predict value after hyperparameter tuning. At the final stage, we conduct SHAP analysis to get the feature importance for the clinical analysis and the view on our model and the result.
In our study, we evaluated 7 different models to predict extubation within a week using a binary classification. Based on the comparison chart in Figure 1, we found that XGBoost performed relatively better than other models in terms of F1 score, negative predictive value, AU-ROC, AU-PR. The Table 2 consists of numerical scores for each of the metrics, which confirms that XGBoost followed by logistic regression are outperforming the other models. We also conducted a preliminary analysis on quantile classification, which is to predict extubation time in different ranges. The ranges we analyzed were about from 0 to 72 hours to 1 week, 1 to 2 weeks, and more than 2 weeks. While XGBoost remained a good performer, we observed a significant drop in the score, indicating future work is needed to improve the quantile classification performance.
On to feature importance. To understand the feature importance, we conducted Shapley additive explanations, or SHAP analysis, and found that the top 5 critical features were the same for both classification models. These include platelets in blood mean, nucleated erythrocytes per 100 leukocytes in blood mean, erythrocyte distribution with mean, urea nitrogen creatinine in serum or plasma mean, and leukocytes corrected for nucleated erythrocytes in blood mean. All were negatively correlated with successful extubation except for leukocytes which corrected for nucleated erythrocytes in blood mean. These features are consistent with other literature, which identified them as biomarkers for predicting extubation time or respiratory failure in previous studies.
We created and tested multiple machine learning and deep learning models on our patient cohort of 9,781 to see if we could accurately predict the successful liberation for mechanical ventilation in the ICU. Of these models, XGBoost was the best performer for both the binary and quantile classification problems posed. Additionally, we confirmed current literature in our discovery that the models we created consider platelet and erythrocyte counts important biomarkers for the prediction of successful extubation. Moving forward, we hope to achieve a high-performing model for the continuous time forecast prediction of the successful extubation event. This model will ideally be applicable across patient datasets and provide clinicians and patient families with critical information to guide important decisions on patient care. Thank you.